real close to the medulla here, and they also have very long loops of Henle that go way down into the medulla, and that's why we call them juxtamedullary. They're also very important in the regulation of the high concentration of urine. It makes us able to concentrate our urine. Now, if we couldn't concentrate our urine, we'd be peeing all the time. Because the urine that we make is usually has a osmolarity of between 0 and 1200 milliosmoles per liter. Normal is 300. That's the same as serum. But we can concentrate it a lot more than that. And that's nice because that means we can hold on to our water. It means we don't have to be sitting around with these damn water bottles all the time, like you guys all do. And then that just makes you make more pee, right?
It's the loop of Henle that does that?
Yes, it happens in the loop of Henle by a process known as countercurrent multiplication, which we'll talk about a little bit. Okay, so just a kind of quick review where we were. Here's the renal corpuscle, which is made up of both the glomerulus and this capsule. Water is literally pushed out through the walls of the glomerular blood vessels into the capsular space, and then it's pushed on downstream. Remember, these are both arteries. This is under high pressure. The afferent arterial approaching it is always bigger than the efferent arterial leaving, and that when it's bigger coming in, smaller coming out, it pushes more out through the walls and makes more filtrate. We call it filtrate. The filtrate then works down its way down through the proximal convoluted tubule here, goes down through the descending loop, the ascending loop, then it goes through the distal convoluted tubule, and then eventually it starts joining into these collecting ducts. Notice that this is a one-man deal. I mean, it's one corpuscle, one nephron, one set of tubes until they get down here to the collecting duct, and then a whole bunch of different nephrons may contribute to the same collecting duct in order to make its way out to it turns into what's called the papillary duct. When it's in the papilla, the pointy thing of the deal, and then on out in the minor calyx. And once it gets to this point right here, we call it urine. Okay, up until that point, it's just been what we call filtrate. Remember that the DCT is really important, mainly probably for the business of secretion of things, getting rid of stuff we know we don't want, like drugs, toxins. One of the questions talks about where do we get rid of penicillin? Well, we get rid of penicillin as a drug. It's in our bloodstream, and we make a conscious effort to secrete it here in the DCT. You notice that this big loop of Henle has two parts. It has thick limb. This part of the tubule up here is thick. This part of the tube down here is thin. Same coming back up, it's thin, and then it gets thick. Let me just give you one little hint that I hope will help you keep those straight. Think of the thin parts of both of these tubules as a screen, piece of screen. Things can go back and forth through it pretty easy. In other words, it's very thin. On the other hand, the thick parts up here are much thicker. The cells are thicker, and the reason they are is because that's where we have all of these pumps. Pumps that pump in sodium, pumps that pump out sodium, pumps that pump in chloride, and so forth. Okay? So think of the thick loops as mainly the area where there's pumps. 85% of all nephrons are cortical, 15% are juxtamedullary. The only really difference is the naming of the vessels. The peritubular capillaries, they're called peritubular capillaries for these guys. They're called vasa recta. Vasa means and straight for the long, straight parts of the tubes down there. Okay. Well, I think we've talked about filtration enough. Just remember that in general, at the renal corpuscle, it's a specialized membrane. It doesn't just willy-nilly let things in and out, but it does it in a rather coordinated way based on the size. So proteins generally don't leak out, although sometimes they do. Blood cells almost never leak out because blood cells are really large. And I'll just leave it at that. I think I've talked about that as well. Let's talk about the pressures that are necessary to make this filtrate. Because if we don't make filtrate, we don't make urine, okay? If we don't make filtrate, we can't get rid of our wastes. So the whole thing starts with filtrate, and without the first step, you can't go farther. Does that make sense? We have these pressures that you need to make yourself aware of. Let's just go to the next slides here. I'm going to skip through these and go to the picture, because I think this is really the best way to look at it. So here's the inside of the glomerulus right here, inside of the blood vessels in the glom. And notice that there's these slits that let things out, okay? And then this is the capsule out here, okay? Now what are the pressures that are working on this business, okay? The first pressure is that blood pressure, okay? This is high pressure in here. Remember, it's caught between the afferent arteriole and the efferent arteriole. There's significant pressure in here, and we call that the glomerular hydrostatic pressure. It's basically just pressure, hydrostatic pressure. That's by far and away the biggest pressure, and that is the main one responsible for fluids going out. We also have two other pressures that are important here. One is called the blood colloid osmotic pressure. Blood is a colloid, right? It's got a whole bunch of stuff floating in it like proteins, and that osmotic pressure means this is more concentrated in here, this is more watery out here, and therefore the water is going to try to get back in to dilute this stuff in here, right? That's basic osmosis. And so that's the pressure going back, called the blood colloid osmotic pressure, pulling fluid back in. We also have this other pressure called the capsular hydrostatic pressure. Now, it's not like this fluid just flows out there and it has no resistance whatsoever, because it flows out there and it has to come down and cone down and get into this smaller tubule. So if you're making enough pee, it's going to generate some significant pressure out in here, pushing back. So the main pressure is the arterial, the hydrostatic pressure pushing out of about 50. The colloid osmotic pressure is about 10 or 25 pushing back. Capsular hydrostatic pressure, just from the pressure that builds up because it's trying to get on downstream, it can't get down fast enough. And it works out to big net filtration pressure of about 10. So the net filtration pressure, which is really the only one that matters, right? You add up all the others, plus and negative, and you come up with that number. 10 is the net filtration pressure that's pushing fluid out into the capsular space and making filtrate out of it. I won't bust you on this stuff here. These are the little pedicels. These are the cells that, the little feet of the podocytes that make up this this membrane right here. It has these slits in it. Let's just let it be at that. The number you need to know about is the GFR, the glomerular filtration rate, and that's the amount of filtrate that our kidneys make each minute. Each minute. In each minute, we make about 125 cc's of filtrate. Well, that's a lot. I mean, I'm not sure I can pee at 125 cc's milliliters a minute. I mean, you know, full bladder, 500 cc's, you got to empty it in 4 minutes. Okay, maybe. But you know, we're making a lot. That's an awful lot of filtrate to be making 24/7. We're pouring tons of fluid out of our bloodstream, out into these capsules. That's about 10% of all the blood that comes to the kidney. So, you know, 90% gets on through, stays in the bloodstream, but about 10% of it leaves it. And then then what are we going to do with it? There's two tests that we do to measure how much filtrate you're actually making. One is called the creatinine clearance test. This is the only one you'll ever hear about in medicine, because creatinine is a chemical that we measure in our blood. I went and had a routine set of blood work the other day, and it had a creatinine level on it. I think my creatinine was 0.9, which is normal. But you can take an S10 because creatinine doesn't hardly get reabsorbed. Once it's filtered out, it's kind of out there. Then you can use the number that's the amount of creatinine in your bloodstream and the amount of creatinine that's in your urine to figure out how much you actually filtered. Okay, and so those are the numbers that we make. Creatinine is a muscle breakdown product. It's filtered at a very regular rate. We do it all the time. There's a better test, but I never saw it ordered one time ever. It's called an inulin test. Inulin is a drug. You squirt it into somebody's vein in their arm. You wait a while, collect their urine, and you check the levels in the blood. You check the levels in the urine. And inulin is just a little bit better than creatinine, but like I said, I never saw it used. Yeah?
So the first one's always a two-part test? Is it always a two-part test?
Yeah. To figure creatinine clearance, you need a blood creatinine and you need a urine creatinine. So think about this. 125 cc's a minute comes out to be about 180 liters, 180 quarts of filtrate a day. We're going to reabsorb 99% of it. This filtration pressure we just talked about. Any factor that changes any of those pressures is going to change your GFR, your glomerular filtration rate. And I think I've already mentioned this, like if your afferent arteriole coming into the glomerulus is this big old huge pipe, and the one on the other end of the glomerulus is this tiny little hose, then you're going to tend to push more out as the blood goes from here through that glomerulus and comes out over here. So, and actually the number one determinant of GFR is your blood pressure. So if you ain't got a good blood pressure, you're probably not making a good amount of filtrate, and that's going to run you into trouble pretty quickly. We have several ways we control it. One is auto-regulation at the local level. Our hormones are released. Those hormones basically are renin and EPO, right? And we also have autonomic regulation by sympathetic division of the ANS, the autonomic nervous system. So what do you think sympathetic stimulation does to GFR? Goes way down. That's right, because it basically makes the big pipe going in turn into a little pipe. That's why you don't make much pee when you're running marathons, as I told you before also. So all of these factors here that are on this slide, I'm not going to go through every one, but let's face it, they're basically, every one of them is all contributing to this amount of GFR for them. The higher the blood pressure, the more, the lower the blood pressure, size of the afferent, size of the efferent, and so forth. You need to understand the renin-angiotensin system. I would just tell you that right up. You probably ought to read through it and understand it. But renin is a hormone that makes you hold on to fluid and makes you hold on to salt. And there you have it. Renin is interesting because there's three different ways that the juxtaglomerular complex. Now, what is the juxtaglomerular complex? Jeez, we haven't gotten to that picture yet, I don't think, but I'll show it to you. But remember, here's the glomerulus, and it goes out. It goes through the proximal convoluted tubule, down through the dip and back. And then the distal convoluted tubule actually is found right here, right next to the glomerulus. In fact, it runs right across through the crotch of the efferent arteriole going in and the afferent going in, efferent going out. Okay? I'll show you a picture in a minute. There's some special cells in there which are part of this thing called the juxtaglomerular complex that release renin. If you release renin, it's going to make you hold on to water and so forth. So I'll just leave that at that. Once you make renin, renin does all these things for you that are just what you'd think. everything from making you hold on to water to simulate you to make you thirsty, so you drink more water. And it also triggers the release of ADH. Remember ADH? Where is it made?
In the hypothalamus.
In the hypothalamus. What part?
Adrenal.
And then it comes down and is released by what part of the pituitary?
Like
The posterior, right? The neurohypophysis. Remember that? Okay. So this renin causes really sharp constriction of the afferent blood vessels to decrease the amount of filtrate you're going to make. Brief, powerful vasoconstriction of these arterioles and the precapillary sphincters to decrease the amount of filtrate you're making. If you're trying to hold on to fluid, you don't want to be making a lot of filtrate. Make sense? And this will not only increase your blood pressure throughout your body. When you add more fluid to the system, it'll elevate your pressures everywhere, which then also increases the pressure coming to the afferent arteriole more as well. Aldosterone is another drug that's tied up in all of this. Remember where aldo is made? Adrenal. Yeah, and we call it a mineralocorticoid. You remember that? And it also accelerates sodium reabsorption. And we'll talk about that, I think, a little bit later. So, if you have a marked reduction in your GFR for some reason, what's going to happen? Well, you're going to start, if you've got a decreased GFR, you're going to increase renin. Renin is going to get turned into angiotensin. That conversion actually takes place in the lungs, by the way. I don't know why, but it does. That raises your blood pressure, increases your blood volume. If you can increase your blood volume and your blood pressure, you're going to start making more GFR. And if you make GFR, that's going to restore the hemostasis from this little cycle. Okay? Negative feedback. Increased blood volume. When you get more blood volume, more water, more blood cells, whatever, that's going to automatically increase your GFR. Does that make sense? If you got more blood pressure driving the tube coming in, you're going to make more GFR. And I think this is just a review. I've said all of these things, so I'm going to skip over that. Let's talk about the glomerular capsule itself, that little cup that fits around the glomerulus. It's simple squamous epithelium. This is one of those things you probably don't remember, but this is one of the tissues that we showed you on the very second day of A&P. When we were showing you what does simple squamous epithelium look like, we were giving you pieces of kidney to look at under the microscope and showing you where those single thin cells were. Well, that was this capsular epithelium you were looking at way back, years ago it seems like, right? All right. These slits, we've talked about them. They just control what can get out. It's all done by size. I used to tell students, this is kind of like a colander. You know when you make spaghetti and you put it in the boiling water and you cook it for 10 minutes or so and it gets nice and soft, and then you take that bucket of pan of boiling hot water with the spaghetti in it and you dump it through a colander. And the colander's got little bitty slits, little bitty openings, and it lets all the water go through, it lets all the salt go through, but it doesn't let the proteins go through. It doesn't let those big pieces of spaghetti go through. So that's the only differentiation it makes here is based on size. Little things get through, big things don't. Does that make sense? Did you like the colander explanation? Yeah.
So when you are peeing out like blood or proteins, is that because there's something wrong with the filtration slits?
No, usually if you're peeing out blood, it's because something downstream is bleeding. Something along the wall, the ureter, or from one of the calyces, or from an infection inside your bladder. Just because it's coming out in your pee, you don't know where it really got into the system.
And what about protein? Because I know that's sometimes...
Yeah, protein, there's a condition called glomerulonephritis, which is a bad disease, actually can lead to chronic renal failure, which means total loss of renal function. And that is a problem with the glomeruli, where the slits do get too big and let proteins leak out. This is a cute little picture. This is really the picture I was looking for a minute ago. Going back to our example, here's the afferent arteriole. This is the big one going in. It's bigger than this one here. You see that? This one's smaller. This is the efferent arteriole coming out. And notice that in between where this goes in and this comes out, there is this thing right here called the juxtaglomerular apparatus. The juxtaglomerular apparatus is where renin is made, and it's the distal convoluted tubule here that takes a loop back and passes right between the crotch of this afferent efferent arteriole. This is called the distal, this is the DCT, and on one side over here you notice the cells are kind of dark. Let's call them the macula densa because they're darker. And then in here, right in the crotch here, there's these juxtaglomerular cells. And indeed, it's these two things together that make up this little complex that we would call the juxtaglomerular complex. Okay?
Why does it pass right there again?
Why? Well, I'll tell you why. That's a very good question. The reason is, what it's doing is when it goes back through there, these cells along here are actually measuring the concentration, how thick, basically, is this urine. Okay? And if it wants to make the urine more concentrated, it secretes more renin. If it wants the urine to be less concentrated, less renin, and lets the water go on through. That's the whole deal with the juxtaglomerular complex. And this always seems weird to me because this is the way it actually lays. You know, here you've got your proximal convoluted tubule up here, comes down, loop of Henle comes back, passes through that crotch, then finishes the DCT, and then heads on out. These are all mechanisms of finely tuning the concentration of the urine before it leaves your body. Yes?
So macula densa and just glomerular cells, they both make renin together?
Yes, I believe that's correct. They both do.
The apparatus is
The apparatus is the combination of these two things right here.
So those two make
I said apparatus, they say complex. Call it the same.
Is the same?
I think I've said enough about this. This is just a more in-depth description of these slits in the walls along through here. Let's just let that be. Remember that this filtration is somewhat passive. It's not active. We're not pumping stuff out or anything like that. It's all just coming out through the colander by pressure. And we're going to then start pulling things back in that got out that we didn't want to. So just remember, we've been talking about filtration. That's the first step of urine formation. So we pump this blood through the glomerulus, we've squeezed a bunch of fluid out, and now we're done with filtration. Proximal convoluted tubule is the next thing we enter. It's the first convoluted tubule as opposed to the distal convoluted tubule. And that's where most of our reabsorption occurs. So once we get out of the capsule itself, we start reabsorbing stuff. This is where we reabsorb a ton of water. This is just, I just know that we reabsorb lots of water and salt as we go down through the, as we start down the loop of Henle. The book goes into a lot of effort and talks about how the epithelial lining of the proximal convoluted tubule is cuboidal, and it has microvilli. The reason it has microvilli is because it is reabsorbing so much water that it needs that extra surface area that villi give it to reabsorb all this water. I think we've said enough about these cells. Let's go into the loop of Henle next, and we're going to go down the descending loop and come up the ascending loop. The descending loop is actually flowing towards the renal pelvis. In other words, they're coming down to the middle of the kidney. through those little pyramid things. Remember those triangular things? The pyramids that we talked about. So, as you're going down the descending loop, you're actually flowing towards the renal pelvis. When you get into the ascending loop, you're actually pulling fluid back, and you're going back away and out towards the cortex again. And then, as I showed you earlier, each limb contains both a thick segment and a thin segment. So what happens in the thick descending limb? Well, it's pretty much like the PCT. It's just pumping sodium and chloride out to get it back in the body. Remember, it's thick. Because it's thick, it has lots of pumps in the wall, and those active pumps are pumping sodium and chloride, getting it back, keeping it in our body and not letting it pass out with the urine. Then we turn around and we talk about the ascending limbs as it comes back up. The thing about the ascending limbs, really when we talk about the loop of Henle, we're really pretty much talking about these juxtamedullary nephrons, because those are the ones that have the kind of length to them, and those are the ones that really make the difference in terms of this high concentrations of fluid in the peritubular fluid. That's where we want to, this is how we're going to make concentrated urine. Thin segments are pretty much screen doors, allowing freely permeable to water, so water can move back and forth to keep everything the way it needs to be. We start back up through the thick ascending loop, and then we get up to the top. We're right back to the renal corpuscle. We're right in the crotch between the efferent and afferent. And this is where the distal tubule begins, moves around a little bit, and that's where a bunch more secretion happens. A lot of secretion. In other words, we're secreting things into the urine that we don't want. Yes?
So back on the nephrons, the juxtamedullary and the, what's the other one? The
Cortical.
The cortical. The difference in between those is just concentration?
Yeah, and length.
And length?
Yeah.
Okay.
And the juxtamedullaries are located right near the border of the medulla.
Oh, and the other ones are
and the other ones are
up
up higher in the cortex.
Okay, okay.
Yeah.
Thank you.
By the time we get to the distal convoluted tubules, we don't have as much water to be reabsorbing, so we don't need all those little microvilli, so you don't see those. Don't look for those under the microscope. I'm not sure I can see them, and don't you worry about seeing them. Just know that when you see a whole bunch of tubules, they're probably proximal convoluted tubules or distal convoluted tubules that are there. When you see long strings of a whole bunch of tubes going in the same direction, you're probably down in the medulla and you're looking at collecting ducts, because they all run together and all go in the same direction. Same with the loops of Henle there. So, three things are happening at the DCT. Mostly there's this active secretion. We're actually pushing out of our body things that we don't want. Ions, acid, drugs. We're selectively reabsorbing sodium and calcium, things we want to keep. And we are also, in the process, concentrating our tubular fluid. I've talked about the juxtaglomerular complex already. And just remember that it's an endocrine structure, basically. It secretes actually two hormones, the hormone EPO and the enzyme renin. And remember, it's formed of two things, macula densa, which is part of that DCT, and the juxtaglomerular cells, which are right there in between. Okay? I think we've been through this enough. Notice over here in the proximal convoluted tube, you'll see these nice little villi. That's where it's really starting to reabsorb the water. I think I've talked about those guys enough too. Basically, what's the point of all of this? What is the point of our kidneys? The point of our kidneys is to keep us in hemostasis. To hold on to the right amount of sodium, to hold on to the right amount of water, to get rid of the things we need to get rid of. And get rid of waste products as well. Yeah?
So when we pee and it's like light yellow or clear, that's just peeing out extra water that our body doesn't need.
In general, when your urine is light colored, it's usually low density. It's not very concentrated. Yes. There's three organic waste products we ought to talk about a little bit. One of them is urea. Remember us talking about urea on that quiz today? Remember? It comes out as ammonia, and it's broken down through the urea cycle into urea, and And the good thing about urea, two good things about it is, number one, it's not toxic, and number two, it's water soluble, so we can pee it out. In order to pee out urea, and it is a waste product, we want to get rid of it. In order to pee it out, we have to be losing water. We've got to have enough GFR and enough urine creation in order to pass out the urea we need to pass out. Creatinine is that muscle breakdown product that we talked about, and then there's uric acid. Uric acid is not really all that closely related to urea, but when you hear the word uric acid, is there any disease that pops to your mind?
Gout.
Gout.
The rich man's disease.
The rich man's disease, yeah, from eating too much
Red meat.
red meat, protein, all that stuff, that's right.
High nobles, royals.
There you go.
Would spend their money on the fancier game-eater meats like
Yeah.
venison and whatnot, and build up uric acid, and they had shitty diets, so they got
The
what they
good
got.
thing to know these days is that if you
You know,
build up too
like
much
you.
uric acid, even if you build it up way high, and it crystallizes out in your joints, that's what gout really is when uric acid crystals form in your joints. And the most common one is your big toe. People that have pain in their big toe, it's pretty easy to jump to the diagnosis of gout for them. But anyway, you can take a pill now that will just break down all that uric acid, and it's not such a problem. Allopurinol is the name of it. A lot of cancer patients are put on allopurinol because, especially leukemia patients, because they're having such turnover in their blood and their proteins, and they're just building up uric acid.
Also turmeric. In the medieval times, the gout incidences went down a lot with the increase of the turmeric trade.
Turmeric,
Turmeric.
that's
What about
a,
shellfish? You're not supposed to eat shellfish when you have gout?
Yay for history.
you know, you guys, you're
Olympic
beyond me.
history.
I just told the patients to take that damn pill every day and they won't have any problem, and they didn't. I don't mean it. You're probably right, I just don't know. So I think this is a complicated, it's a long slide, but basically what it says is that you can't get rid of these waste products unless you've got water flowing out of you for it to dissolve in and pass out with, okay? So you've got to have water loss in order to get rid of waste products. In other words, if you aren't drinking any water and you don't have a way to get rid of that stuff, and so it does build up in your system. We actually used urea numbers, BUN, blood, urea, nitrogen. BUN is a pretty good way of telling whether somebody is hydrated enough or not. If they haven't been drinking anything for a few days, their BUN is liable to pick up. It might get up to 30, 35, normal's well less than 20. If they're having more troubles than that and their kidneys aren't working well, you can use urea levels in the blood to kind of tell when they need to be dialyzed. Once your urea level gets up to 80, 90, 100, it's time to start thinking about signing them up and getting them on dialysis because their kidneys just aren't working. All right, let's talk about this business of concentrated urine for just a minute. Normally, we can produce concentrated urine up to 1,200 to 1,400 milliosmoles per liter. In other words, about 4 times as concentrated as our